webinar. I know that today's topic will bring up a number of questions from you. So you may type your questions in chat box, and I want to let you know that we will address as many as we can in the time we have today. And I welcome and request our NBMS National Webinar Coordinator, Professor Dr. Somshekhar, to start this session. Welcome, sir. Over to you.
Thank you very much, dear trainees. As you know, this last 1-2 months has been a head and neck series for us. As I always say, what is an inguinal hernia case for a general surgeon student to pass? You must answer every question to the fullest, not to get gold medal or distinction, but just to pass. One question you miss in hernia, you don't pass in general surgery. Similarly, in surgical oncology, MCH and DNB, head and neck case is not to get gold medal, not to get first rank, but to pass every question you are supposed to know the answer for that. And that is the very, very weak point of most of our students. They will get minimum 2 cases in practical, sometimes 3, and lot of theory questions. Because it in itself has become a super subspecialty under surgical onco, which itself is a vast, and now even in head and neck laryngeal surgeries, then parotid and salivary gland tumors, thyroid, skull base, everything is again become different. So that's why, we tied up with, my great senior fatherly figure to all of us who did MCH, Dr.Kaustubh, who is the director of Asta Oncology Associates and is also the director of HCG Oncology Center in Ahmedabad. More than anything, he was one of the first persons among our surgical who traveled across seas to MSKCC, learned and mastered not just surgical onco and head and neck, also minimal, microvascular. He's one of the few guys who showed in a time when none of us even dreamt of traveling out, who mastered the skill, came back and established this unique specialty. More than that, he is a very humble person, excellent surgeon, great teacher, and runs a lot of master courses through OM and also many other Association of Head and Neck Society, India International. More than that, he analyzes every paper topic so well. If you need a proper unbiased view of any paper or studies, you ask him. He will never take it lightly. Beautifully, he analyzes. Those of you who attended his multiple webinars, teaching sessions, interacted with him in national international conference, know that he never speaks lightly over the shoulder. Thoroughly, he will analyze it. And more than that, he is a humble human being. As you go up, people fly out, but he is somebody who has his foot on ground. We all looked upon him when we were students to come up. Great inspiration to all of us. And he is the reason our head and neck series has happened. He spoke to all his colleagues and built up this whole thing. Hats off to him and great thanks from NB, DNB students and me. And today is going to cover a very tough topic, surgical margin, the holy grail in the oral cancer. Thank you very much. And Kaustubh, on behalf of students, myself, NBA board, heartfelt thanks. We can't give any money or anything to you, but you and your family has our prayers and blessings of all the students with your whole life for this endeavor you are taking. Thank you very much, and over to you.
Thank you so much, Som. I know you have a very special bias for me. Thanks for all those kind words. And yes, I need blessings from everyone that I continue, not surgery, but I continue teaching, which is very close to my heart. Today's topic is surgical margins. This is one of the most important topic for oral cancers. The reason is that the surgery is the mainstay of treatment for oral cancers, and every surgeon should know what surgical margins they should take in that particular case which they are trying to cure. 70% of all head and neck cancers are oral cancers, and largely fifth decade of life afterwards, but migrating to younger age recently. 80% are tobacco related. All these things. These are written in all the literature. These are Indian literatures. We can see that the estimated number of incident cases and death for lip and oral cavity, both sexes, all ages, you can see India is topping this list, even in mortality, even in the incidences. And that is the reason why Indian surgical oncologist must know everything about head and neck cancer. There is a demographical difference in oral cancers in India. If you see west, central, north, and part of east, they have buccal mucosa cancer, while northeast and south has more of the tongue cancers. And that is the reason why you see wherever you are getting your training as DNB, you will be seeing more cases of tongue versus buccal mucosa. When we talk about margins in oral cancers, two very important things you must understand is that margins are consisting of two issues, mucosal issues and deep margins. The mucosal margins and deep margins. And mucosal margins, when we talk about, their consideration vary between a normal mucosa and a patient who has submucous fibrosis in our country. And the deep margin differs in tongue and buccal mucosa, and they have separate issues which we will go through in a while. There are different subsets of oral cancer, oral cavity, and you all know that. I don't want to go into that detail. What you need to know is that a perfect anatomical knowledge is fundamental for any surgeon doing surgery in that area. So you must know intrinsic, extrinsic muscles, what are the depth, what is the sublingual space, what are the nerves and vessels going there, what are the muscles, extrinsic and intrinsic muscles, what are the bony relationship. And the same way, you must know what is a masticator space for buccal mucosa, and what is the difference between a masticator space and infratemporal fossa. And knowing that will not only give you an ability to stage the patient better, but also to do the surgery better as far as the margins are concerned. You must know the boundaries of all those deeper parts of oral cavity cancer patients. So that brings us to two very important questions. What is an ideal margin for oral cancer, and how will you achieve that? So according to NCCN 2023, the ideal margins are the distance from invasive tumor front, that is 5 millimeter or more from the resected margin. That is a standard teaching. Closed margin is 2 to 5 millimeter, and a positive margin is 1 millimeter or less. Carcinoma in situ or invasive carcinoma at the margin of resection. If carcinoma in situ is present and if additional margin can be obtained, that is the favored approach. Carcinoma in situ should not be considered an indication for concurrent postoperative systemic therapy or radiotherapy. And severe dysplasia at the margin is also considered as positive margins now, because the gray area between severe dysplasia and carcinoma in situ is now vanishing. Most of the surgical pathologists would consider severe dysplasia and carcinoma in situ as two sides of a single coin. So when we have positive or closed margins, we have two options. One is revision surgery, but you cannot target well the original margins when you go back after 10 days, 15 days, 1 month, because you have done a reconstruction in oral cancer, or your deep margin orientation is lost. People have recommended CTRT, but the toxicity of this unnecessary treatment, if you would have taken appropriate margin at the first go, is something which is the most desirable thing from patient side and from the consultant like us. Compromising options of treatment at second primary is the issue when you use chemoradiation or radiation for an avoidable indication. when that patient develops a second malignancy, there is an issue with re-radiation, or maybe a third malignancy if you have managed well that patient's. And in spite of adjuvant chemoradiation, the data says that the prognosis remains poorer compared to a patient who has upfront per primum negative margins. So if you don't give chemoradiation to this positive margin patient, they have worse prognosis. But when you give chemoradiation, then also it doesn't come back to the status of a patient who has a per primum negative margins. So margins are the strongest and only modifiable prognostic factor in the hands of oncologists, surgical oncologists. Initial resection offers the best chance to have clear margins. If initial margins are grossly positive, even re-resection is associated with higher chances of local relapses due to the possibility of ambiguity, as I told you about whether the extra margin from the tumor bed corresponds to the area of positive margin. Close margin, these are the new articles, 2023 meta-analysis, which says that close margin as a very single adverse prognostic, mind well, not positive margin, close margin as a single adverse prognostic factor without postoperative adjuvant therapy has an acceptable local control in patients who have close margin status as their only adverse figure. So independently, only one factor, all other factors are normal, only your margin is close, there can be an option of not giving adjuvant and keeping the patient into a close follow-up. This is what the 2023 March head and neck meta-analysis says. What is the upper limit? How far you should go? So margins beyond 7 millimeter did not translate into survival benefit. And when we say this, we have to understand that this 7 millimeter is not in the patient, but this 7 millimeter is when you are examining the specimen once the specimen is removed. So you must aim at more because there is a margin shrinkage. Amount of shrinkage differs according to the site. Buccal mucosa is highest, followed by tongue, floor of buccal cavity, retromolar trigon, gingiva, and therefore it is recommended that surgical margins should be increased by about 25% to ensure adequacy, and that contracture percentage according to the tumor site be considered. Also, type of surgery used can affect the margin status, like you have used a knife or a laser or a cautery. And also formalin fixation will cause further shrinkage when your specimen goes for the definitive histopathology. So in general, 1 centimeter is taken as a surgical margins on operating table, providing the shrinkage according to the site of tumor and also presence of submucous fibrosis, which can also contribute to the shrinkage. And that's the reason why your ultimate margin should be 5 millimeter or more. There are some special situations like post NSCT cases where though your tumor has shrunk visibly, you must try and target the previous disease margins, because till today there are not enough data which says that when there is a chemotherapy induced reduction in the tumor, it is concentric or there are isolated tumor cells at certain areas, and then there is a normal area, and then there is again a primary cancer. So that's the reason why you still need to remove the disease with the previous margins if possible, unless there is an extremely critical structure. Post radiation, wider margins, because there are dysplasias, because there are submucosal tumor, you must take vital margins. Background of field cancerization, you must take entire dysplastic area to remove and block with the lesion, meaning that if there is a buccal mucosa field cancerization, you must remove that buccal mucosa from upper alveolus to lower alveolus and from angle mouth to retromolar. And the same goes with submucous fibrosis, because whatever submucous fibrotic mucosa you keep in patient, that can throw a second malignancy or a recurrence at a later date. How to achieve ideal margins? There are 5 components we will discuss: clinical, radiological evaluation, surgical evaluation, pathological, and newer technologies. So pre-operative clinical assessment is one of the most important thing which gives you an idea that how good or bad this tumor is and what are its involvement clinically, where what important structures you will have to remove in order to take adequate margins. There can be vital tissue staining like toluidine blue, indigo, carmine, or fluorescent visualization. Like toluidine blue has affinity towards DNA and RNA, and it has been since years shown that can give you or throw some light at the margins where it will give you a suggestion that you have to go beyond the visible margins which is there. Indigo carmine is also one of the agent. There is a fluorescent visualization also now coming in an experimental way, and narrowband imaging also. But these are not routinely used at all places. These are used only in some special circumstances, and they are not yet recommended across the institutes as a standard routine. So what else helps you? And that brings us to radiology. In a seemingly innocuous tumor, CT MRI may reveal more disease and actually extend the span of surgery to the areas where the tumor has gone beyond your visual effect. The margins to be taken can change drastically by imaging, and this is especially true for the deep margins. You can have a perineural spread to foramen oval in a patient who has a retromolar disease, but not seen as a very advanced case. An MRI can show you that. Even the infratemporal fossa, supranotch or infranotch involvement can only be judged by imaging, and you cannot examine and see it from just your naked eye and palpation examinations. So once you have this radiological and clinical assessment, you must develop in your mind 3-dimensional thinking. This is what I tell all my DNB residents and fellows, that at the end of 3 years, you must have 3D thinking. You don't see a tumor in your mind as a 2D. As soon as you start seeing the patient, you try and apply a jigsaw puzzle in your mind about the 3-dimensional extent of that tumor. And once you are ready with your clinical examination and the entire radiological pictures, you must have a fair idea of 3-dimensional anatomy of that tumor. That leads to proper surgical planning for that patient. So the main principles of surgery are en bloc resection of primary tumor with good margins. Thickness increases risk of metastasis, so elective node dissection, perineural invasion suspected when tumor is around the sensory or motor nerves. Frozen section of nerve ends may be carried out. 4 possible medullary invasion of bone. Frozen section of marrow may be indicated to decide on plan of action. So what is considered as an adequate margin? There is a literature way back in 1978 by Dr. Jatin Shah, Elliot Strong, and Dr. Kevin, which arbitrarily told us that 5 millimeter should be our margins based on their studies. And it's true till today. We follow this till today. And that shows that how a critical evaluation of your data gives you an insight to the best outcomes for your patients. 2023 head and neck, this March issue shows the meta-analysis, and it still says that 5 millimeter is the standard. However, this meta-analysis shows that from 4 millimeter to 4.9 millimeter, the clearance had the same local recurrence risk compared to 5 millimeter or more. So this meta-analysis has reduced 5 millimeter to 4 millimeter. These are 7 studies, 2,215 patients. So quite a robust data. However, this data is still not a prospective randomized data. When the margin is positive, there is a definite loco-regional failure rate which increases to almost double, and the survival reduces to half. Mucosal margins are clearer to assess than the deep because mucosal margins are clearly seen. Deep margins are mesenchymal tissue, muscles, connective tissue, bone, neurovascular channels. They are difficult to delineate, whereas surgical margins can be precisely cut on the mucosa. And this is the reason why radiology is most important, imaging is most important for your patients when you are operating. And that is why they are more important, the deep margins are more important to be addressed extremely precisely. A successful surgeon will have a negative deep margin. An average surgeon will always have a mucosal negative margin, but deep margin is what is the most important thing when we are talking about oral cancers. And that's the reason why it brings to these kind of glossectomy classifications. Like type 1 is the mucosectomy, where you have good margins when you are evaluating the patient properly. Type 2 partial glossectomies. When the tumor is more deep, there is a hemiglossectomy, type 3A and B, where you remove accordingly. Type 4A is subtotal glossectomy, and 4B is near total glossectomy. You can see depicted anatomical picture. And then type 5 is a total glossectomy, where you remove the intrinsic, extrinsic muscles, both lingual arteries, hypoglossal, lingual nerves, and floor of mouth. This is done for massively infiltrating lesions. And glossectomy type X is extension or excision of adjacent structures like digastric, epiglottis, larynx, lateral wall of pharynx, or mandible. And the same way it goes for buccal mucosa, the compartmental resection, which has been propagated since last few years in India, giving much better results, where you remove the entire infratemporal fossa, either with the maxilla, where it is known as a classical compartmental resection, or if the tumor is not touching the maxilla or pterygoid plates, then you can do a classical infratemporal fossa clearance like this, where you can see the foramen ovale, you can see the roof of infratemporal fossa, the sphenoids, you can see below the internal carotid artery, and all these structures are clearly seen, and there is no fibrofatty tissue or muscle kept. So this is the specimen which shows the infratemporal fossa tissue, which is this tissue. This is the glenoid fossa here. And when you see these patients after a few years, you can see that the entire fossa is clear with a reconstructed flap. That brings us to frozen section. This is a valuable intraoperative guide in management of squamous cell carcinoma, as it helps to make prompt therapeutic decisions that may prevent surgical reintervention or postoperative radiotherapy. Olson said that it does result in low rate of local recurrence and re-excisions. What about the bony margins? So you can have a thin slice, or you can have a curettage and send it for frozen section. It has its limitations, but still, if it is positive, you have a lead to resect more. In general, you must resect 1 centimeter of bone from the erosion on your imaging. So that is what is an important suggestion, that 1 centimeter on bone is the most important margin. It doesn't shrink, mind well. So that's why 1 centimeter on bone will remain 1 centimeter or maybe 9 millimeter on the final histopathology report. If you have resource constraints or cost effectiveness issues for frozen section, there is a paper by Pankaj and Shubda that 7 millimeter gross negative margin assessment by surgeon intraoperatively can avoid use of frozen section in most of the cases. Now that brings us to what you do once your margin is positive or close on frozen section. So you do margin revision, but does it work? When we go through the literature, most of the papers say that the control is worse even with revision. And there is no effect on survival in one of the paper, 50 patients. And in one paper, there was a trend towards worse local control. So these are the limitations as people understand. This is a meta-analysis. Does clearance of positive margins improve local control in oral cavity cancer? And this meta-analysis says that margin revision of initially positive margins to clear based on frozen section guidance does not equate to an initially negative margin and does not significantly improve local control. So when you have these kind of literature, there are few literature which says that there is advantage, but when there is a huge meta-analysis like this and suggesting that it does not significantly improve local control, what comes to your mind? Should you do it or you don't do it? But the question is not to you. The right question to ask for these papers are, why don't they work? Why revision doesn't work? And there are three, according to me, there are three main reasons. One is tumor biology, which is a non-modifiable at present. Lack of proper sampling, which is modifiable. Lack of precision revision, which is modifiable. None of these studies mentions the precise method by which the revision was ensured to be foolproof. And that is the issue where I defer to these papers. So there are two major modifiable issues. One, which is the right way to send margins to pathologists, how to send the sample for frozen section, the sampling error. And another is, which is the right way to revise the margin, meaning that how you should do a revision once your margin is close or positive. Let's take the first one. What is a true margin? Is it the one taken from the tumor bed by surgeons once he removes the specimen and then he starts cutting the tumor bed margin and sending it for frozen section? Or the one which is obtained from the resected specimen by the pathologist when the whole specimen is sent to the pathologist and he takes the margins from the specimen. So there are very good paper, and one of the most important paper which I'm going to quote in detail is by Simeon Choisa, University of Pittsburgh Medical Center. And this paper is really changed the practice in United States. The second paper is again by Choisa, early oral tongue squamous cell carcinoma sampling of margins from tumor bed has a worse local control. So as I told you, there are two margins, two type of margin. One is this margin where you can see that tumor bed defect is done and then the surgeon cuts the margin, and this is the specimen which is sent to the histopathology frozen section, and the margins are cut from the specimen taken by the pathologist. So there was a question answer project sent to multiple institutes. 280 people responded. There were T1 and T2 tumors. PN0 primary endpoint was local recurrence, and the workflow comparison was like this. In group 1, there were T1, T2 tongue patients whose specimen was sent for the margins on frozen section, and frozen section reported margins to be negative. The second group had a same way the specimen sent, but the margins were positive on reporting of the frozen section, and then revision margin were sent by the surgeon and they were reported as negative. And group 3 are the patients where specimen was not sent, the tumor bed margins were removed by the surgeon and sent for frozen section with nomenclature which margins are what. So these three groups were compared. There was no difference in age, gender, smoking or alcohol abuse in all these three groups. Tumor differentiation, pattern of invasion, perineural invasion, LVI, pathological T1 versus pathological T2, everything was similar in all these three groups. And the adjuvant treatment was also similarly given in all this. So these were the stratified groups. What it concluded? It concluded that sampling of margin from the tumor bed is associated with the worse local control. There were more frequent positive margins in the final specimen. There were narrower margins. There were confusing multi-part pathology report. Margins from the resection specimen are the only prognostically relevant margins, meaning that when you send the specimen for frozen section, it is the most relevant margin. Formal resampling of resection margins should be done by pathologists regardless of tumor bed sampling, and still better if the surgeon can go in the frozen section room and can take margins from the specimen along with pathologist. So in summary, margins derived from specimen by an expert surgical pathologist or tumor bed margins taken by surgeon from the patient can have different impacts on true margin positivity and residual microscopic disease in patient. Negative specimen margins on first resection gives best outcomes, followed by revision guided by resected specimen margins reporting. And the worst is the outcome of random tumor bed margins taken by surgeon without specimen margin reporting. So that brings us to this paper of randomized control trial of 71 patients where specimen-derived margin assessment led to significant improvement in the rate of negative margins. And based on these data and others who replicated, CAP, College of American Pathologists, and WHO changed that statements. Now CAP recommends reporting margins from the specimen. Even when a surgeon has sent the tumor bed margins, the pathologist is supposed to report the margins from the main specimen. And WHO Blue Book also says that margins from resection specimen rather than the tumor bed gives better prediction of local control. So that brings us, we have understood how we should sample. Now it brings us to, once if it is reported positive, how you revise the margin. So when your specimen is sent, there are these are the two ways by which you can resect. You can have the margins. So if they say that this margin is positive and if you resect only this much, then they will report this as negative because it is this margin which you have sent, but you have not sent the margin over here, which is this margin. So that is the reason why your revision must be optimum when the margin is positive. Now that brings us to a dilemma. Many a times it's difficult surgical challenge to revise the exact margin from the tumor bed. It may not be representative, leading to poor oncological outcome as we saw in this previous slide, where you miss the perfect revision. Or it may be an unnecessary over resection from an unrelated area. And that gives patient a poorer outcome for quality of life. There was an unnecessary part of tongue which was removed, which was not required. So either it can give a poor oncological outcome or it can give a poor quality of life outcome if your revision is not from an extremely appropriate area. So what we do, we started doing color coding, and this was taken up from the idea of transoral robotic surgery, for which I got trained in UPenn with Dr. Weinstein. Each specimen is color coded and the margins are taken by the pathologist in the presence of surgeon, and all specimens of squamous cell carcinoma at our center are now color coded. We have more than 6,000 specimens now evaluated so far by color coding. And we have published this also. So what we mean by color coding is this. You color code all the margins, red anterior, green superior, yellow inferior, blue posterior. You have a ruler there in your photograph, and you take a photograph and then you ink the base also. And this goes to the histopathologist where he will report the margins on frozen section. It is photographed in operation theater and then it is sent. During excision or after gross examination in OT, if there is a doubt, surgeon will ink the corresponding margin or part of base in tumor bed, meaning that on the patient side for revisiting that area if required after frozen report. So immediately when you resect the tumor, you examine it properly, and if you feel that one of your margin seems to be near or your base seems to be near, you ink that area in patient at that moment only, so that you don't forget when frozen section report comes from where you want to remove the appropriate margin. In the event of a positive margin or closed margin, the pathologist is required to inform the color of margin and exact distance in millimeter from the junction of colors where there is a doubt. So at our place, the pathologist will say that the margin is focally positive for 2 millimeters from the junction of yellow and blue towards blue. So we will exactly know when this is said, I am going to take 2 millimeter from here junction of yellow and blue 2 millimeter focally. So corresponding to this margin, we will take a further bigger margin with adequate clearance. So it generates a great confidence for precision to surgeon and pathologist being on the same page. These are few other, and this is the ink which is shown on the photomicrograph. You can see the positivity, how far is the tumor from that ink margin. Color coding of the specimen allows the surgeon and pathologist to speak the same language, being on the same page regarding margins of specimen. It maintains orientation of grossed and dissected specimens, enabling surgeons to revise the appropriate margin or the pathologist to revisit the gross specimen if required later, confidently allowing further sampling if needed. There are some additional methods: intraoperative ultrasound guided deep margin resection. There are few slides I have added from one of my good friend, Dr. Snehal from Memorial Sloan Kettering Cancer Center, and also from Dr. Satakshi at Apollo, who presented surgical margin meeting yesterday only. Microendoscopy. This is again coming as a tool whenever there is a irregular margin or field cancerization type of issues. Optical technologies are coming up. There are multiple optical technologies available which are being tested in real world setting, and it is also known as optical coherence tomography. This is a non-invasive intraoperative scanning method. Narrowband imaging is also one more tool which you can use. Indocyanine green, you know, the robotic surgeons, they use it for robotic resection. You can use that also for getting your margins. Molecular assessment. This is also being tested in lab and research facilities right now. P53, Ki67, KRAS, EGFR at margins. So these are, and the gene signatures, these are all being researched right now. These all methods are work in progress. It has yet to come to standard clinical practice. Frozen section still remains the best tool for intraoperative margin assessment at present. If you have limitations, take more than at least 7 millimeter margin on your gross specimen. Send your specimen for frozen section. The effect of surgical margins on outcome of patients with head and neck squamous cell carcinoma. This is a single institutional experience, and it says that there is a significant impact of positive surgical margins on outcomes in univariate and multivariate analysis both, and that adjuvant radiotherapy chemotherapy cannot fully compensate for the close or positive margins. And this is an NEGM data. It says that the single most important prognostic factor for squamous cell carcinoma of head and neck is complete surgical removal of the neoplasm. Nothing can improve prognosis more than an adequately resected specimen with adequate negative margins. So, surgeon is the biggest prognosticator. This was said by Oliver Bears, and it's true even today. Thank you.
Thank you very much, Dr. Kaustubh. Trainees, you may type your questions, comments in the chat box. So, Dr. Kaustubh, you may stop sharing the screen now.
Okay. Is it
right
stop now?
Sir. Yes, sir. Now at the right bottom, just open the chat box and you may address the questions.
So, how much millimeter depth of invasion should be considered Okay, let us go to the first. What should be the margin in verrucous carcinoma? It should be 1 centimeter, the same as invasive cancer. Dear trainee, always okay. Open link, okay. Sir, as you said, 1 centimeter margin for bone is from bone involvement, and if it is soft tissue or paramandibular, it is more than bone involvement. Is margin for bone is 1 centimeter for soft tissue involvement. So paramandibular disease, you have to take the bone where the paramandibular tissue is stuck to the bone. So from there you have to take 1 centimeter. So most of the gross paramandibular involvement, even without bone involvement, results into a segmental mandibulectomy, and that is the reason why Dr. Devendra Chokar's paper, which says the experimental role of neoadjuvant chemotherapy for organ preservation of mandible. You can go through that paper. The clear indication of compartment resection in tongue lesion, current view on it. So whenever the depth of the tumor involves the extrinsic muscles, whenever it involves the neurovascular bundle, compartmental resection is a must. Patient selection for NSCT in tongue cancer, what will be the margin after NSCT? I did elaborated that, and a fixed tongue, extrinsic muscle involvement, a tumor where you are not clear that you will be getting a negative margin, a tumor which is reaching to hyoid bone. These are the cases where you will give neoadjuvant chemotherapy, but at the end of the day, you will do a compartmental tongue resection. How much millimeter depth of invasion should be considered as adverse feature in oral cavity cancer? So that is the reason why the TNM has changed and has put the depth of margin in consideration with staging. You can go through it and decide 5 millimeter, 10 millimeter. These are the cutoffs. What is your experience on specimen driven margin versus defect? I elaborated that very well. At our place, all the specimen goes for frozen section rather than the defect margins. Your comment on mild moderate dysplasia on one of the margin on frozen section. Mild and moderate dysplasia are allowed. Severe dysplasia is almost carcinoma in situ. You can't allow severe dysplasia at your margins, so you must revise. And this is the reason why I say that field cancerization and submucous fibrosis cases, you should remove the entire subsite, meaning that if it is a right buccal mucosa, you remove it from upper alveolus to lower alveolus and from angle mouth to retromolar, the entire mucosa. Which ink or dye is used to color code the specimen? It is very simple colors, acrylic colors, and you apply a acetic acid spray over it so that it fixes to the tissue. You can go through our article in Indian Journal of Surgical Oncology. What about skin margin? Skin margin, 1 centimeter, of course. Lateralized lesion of tongue for margin to remove mandible or not, prognostic implications. So what I do is a tongue cancer will not involve the mandible or touch the mandible unless the floor mouth is involved. So once the floor mouth is involved, you'll have to realize how far is the disease from the inner gingiva, the inner alveolus mucosa. So if the tumor is creeping on the inner gingiva, bone is free, you need to do either a inner cortical marginal mandibulectomy along with your specimen removal, or you may resort to neoadjuvant chemotherapy and then do the surgery for organ preservation. When you say margin, when a pathologist study a shaved margin or so you know at almost all institutes, it is the shaved margins which is more representative rather than a radial margin. We have There is only, Navneet, there is only chat box or there is a QA also somewhere?
I have forwarded the questions to the chat box. You have addressed
Okay,
all.
fine.
There's
I have
one more
addressed all
from
them.
Dr.
Yeah.
Soumya.
Okay. The last one was from Dr. Mishra, and it's for the lip, vermilion, or mucosa, or outer skin, all different margins. No, it's 1 centimeter minimum on definitive specimen, 5 millimeter. I think we have finished all the questions.
Is there any concluding remarks?
Yeah, so this is for your exam now. In your exam, the sacrosanct facts which you are supposed to say is not 4 millimeter margin as the meta-analysis says. It has to be 5 millimeter as your answer. But if there is more discussion, elaboration, you can point to this paper, which is a huge meta-analysis published recently. The same way, there might be questions for marginal mandibulectomy and segmental mandibulectomy, which we have not addressed. Marginal mandibulectomy can be done only for very superficial cortical erosions, or the tumor which is sitting there without mandibular erosion, or a tumor which is in buccoalveolar sulcus, but you get a clear-cut 1 centimeter bone margin below the paramandibular soft tissue margin. So these are the cases where you will do a marginal mandibulectomy against the segmental mandibulectomy. I think I have addressed all the issues, but if there are any issues, you can email me, and I have given you my numbers also in my presentation. So you can ask me, call me, and at an appropriate time, I will get back to you for all your questions. All the best for your future endeavors to pursue surgical oncology. And if you are in India, more than 50% of your surgical oncology work as a general surgical oncologist is going to be head and neck. Don't take it lightly. And as Somsekhar said, 2 or 3 cases, major will be, long cases will be head and neck in your exam. Thank you. All the best to all of you.
Yeah, thank you. Thank you very much, Dr. Kaustubh Patel, for the presentation, and thank you very much, trainees and faculty members, for joining. Thank you.
Thank you.